everybody. The topic of discussion for today is rectus sheath or rectus fascia. It is a pair of aponeurotic resilient covers, one covering each rectus abdominis muscle. It is formed by aponeurosis of external oblique, aponeurosis of internal oblique, and aponeurosis of transversus abdominis muscle. It extends from Z5 process and 7th, 6th, and 5th costal cartilages above to body and crest of pubic bone below. Its medial border is almost a vertical line which indicate lateral border of the linea alba, and its lateral border is formed by linea semilunaris, which extends from 7th costal cartilage to pubic crest. The anterior wall of the rectus sheath is complete, that is, it extends from one end to the other. It is firmly adherent to the rectus muscle by three tendinous intersections. The posterior wall of the rectus sheath is incomplete, that is, it covers only the middle part and is deficient above the costal margin and below the arcuate line. It is free from the rectus muscle and is divided into three parts for description. Number one, above the costal margin. Number two, below the arcuate line. And number three, between costal margin and the arcuate line. Now we come to the formation of the rectus sheath. First, above the costal margin. Anteriorly, it is formed by aponeurosis of the external oblique, whereas posteriorly it is deficient, hence muscle rests directly on the 7th, 6th and 5th costal cartilages. Number two, below the arcuate line. Anteriorly, it is formed by aponeurosis of all the three muscles, that is transversus abdominis, external oblique and internal oblique. Out of these, transversus abdominis and internal oblique are fused, whereas the external oblique remains separate. Posteriorly, it is again deficient and muscle rests directly on the fascia transversalis. Third part, between costal margin and arcuate line. This is the part of the rectus sheath which is complete both anteriorly and posteriorly. Anteriorly, it is formed by aponeurosis of external oblique and anterior lamina of aponeurosis of internal oblique muscles. Posteriorly, it is formed by posterior lamina of aponeurosis of internal oblique and aponeurosis of transversus abdominal muscle. And this part rests directly on the fascia transversalis which lies behind it. Now the arcuate line, it is a concave margin that lies midway between umbilicus and pubic symphysis and defines the lower limit of posterior wall of the rectus sheath. It is formed by combination of lower free borders of posterior lamina of aponeurosis of internal oblique and aponeurosis of transversus abdominis muscle. This is a site of weakness where herniation of the abdominal contents may occur. Now we come to the contents of the rectus sheath. As regard the muscles, there are two. Rectus abdominis, the chief and largest content of the sheath, is broader above and narrow below and extends from one end to the other. The second is a small pyramidalis muscle which lies in front of the lower part of rectus abdominis muscle. As regards the arteries, they run behind the muscle, and there are two arteries, one superior epigastric artery, which is one of the two terminal branches of the internal thoracic artery. It enters between costal margin and xiphoid origin of diaphragm, runs downward in the sheath. Second is inferior epigastric artery, a branch of external iliac artery. It pierces fascia transversalis at lateral border of rectus abdominis, enters sheath behind the arcuate line, runs upward. Both arteries anastomose in middle part of the rectus sheath behind rectus abdominis muscle. Veins are in the shape of vena comitans, which run along the superior and inferior epigastric arteries. Hence, superior epigastric vena comitans, which accompany superior epigastric artery, open into internal thoracic vein, whereas the inferior epigastric vena comitans travel along with the inferior epigastric artery and open into the external iliac vein. As regard the nerves, we can see the terminal parts of lower 6 intercostal nerve inside the rectus sheath. Let us have a brief review of the new concept of rectus sheath. Rectus sheath is formed by decussating fibers of three pairs of anterior abdominal muscles. Each muscle forms a bilaminar aponeurosis at lateral border of rectus muscle. Fibers of three anterior leaves run obliquely upward, and the three posterior leaf fibers run obliquely downward at right angle to each other. The anterior lamina of rectus sheath is formed by anterior 1.5 of the muscles, whereas the posterior lamina of rectus sheath is formed by posterior 1.5 muscles. Fibers of each layer decussate to opposite side of the sheath and also decussate between anterior and posterior sheaths. Hence, muscles are said to be digastric with the central tendon in the form of linea alba. And the digastric muscles are said to be right external with left internal oblique, left external oblique and right internal oblique, and both the transversus abdominal muscles. Clinical significance of rectus sheath. As this sheath is durable, resilient, fibrous covering, it checks bowing of the rectus, especially during flexion of the trunk. Hence, it increases efficiency of the muscle. It maintains strength of anti-abdominal wall and protects the muscle and vessels within it. Rectus sheath hematoma. An accumulation of blood inside the rectus sheath, which occurs secondary to rupture of epigastric vessel or muscle tear. It occurs spontaneously or after trauma. It is an uncommon condition, but relatively common after 60 years of age and present with pain and bruising. Most rectus sheath hematoma clear up on their own and do not require medical treatment. Bilateral rectus sheath block. This nerve block provides intraoperative and postoperative analgesia for midline abdominal incision and is commonly used in the pediatric patient for umbilical hernia repairs. This block is acquired through an ultrasound guided procedure at or below the level of umbilicus. First, the rectus abdominis muscle and posterior rectus sheath are identified. Then a needle is inserted through the rectus abdominis until tip reaches the space between muscle and posterior layer of rectus sheath. Now we inject 10 to 15 milliliter of local anesthetic, and this procedure is repeated on the contralateral side as well. This blocks the anterior cutaneous branches of intercostal nerve in the area of T9, T10 and T11 dermatomes. Linea alba is the tendinous band present in middle of anterior abdominal wall between two recti muscles. It is attached to the lower end of sternum above and to the top of anterior part of pelvis below. Superiorly, it is broad because of larger gap between the recti muscles. Inferiorly, it narrows as the two recti are almost in contact with each other. At its lower end, it divides into two lamina, superficial and deep. Superficial fibers are attached to symphysis pubis in front of rectus muscle, whereas deep fibers are attached behind the rectus to the posterior surface of pubic crest. As regard the functions of the linea alba, it keeps right and left abdominal muscles separated, as well as it stabilizes anterior abdominal wall as it balances contractile forces from muscles of both the sides. As regard the clinical significance, first is divarication of recti is emergence of larger gap between recti, especially in its lower part. It occurs because linea alba softens and stretches as the abdomen enlarges during pregnancy. Second are the para-umbilical hernia. This occurs this type of hernia occurs due to weakness of linea alba around the umbilicus. Third variety is epigastric hernia, which occurs due to weakness of linea alba and its stretching or stretching around the blood vessels. Linea semilunaris is a vertical curved groove or line which is especially seen in bodybuilder. It corresponds to the lateral margin of rectus abdominis in the anterior abdominal wall. Extends from tip of ninth costal cartilage to pubic tubercle. It is formed by aponeurosis of internal oblique at its line of division to enclose rectus muscle. It is reinforced anteriorly by external oblique and posteriorly by transversus abdominis above the arcuate line. As regards the clinical significance of linea alba, a very rare variety of hernia, the Pygelian hernia, is seen at the level of the arcuate line. It is protrusion of abdominal contents through a defect that occurs at the meeting point of linea semilunaris with arcuate line. It usually involves attenuation of transversus abdominis and internal oblique at this junction. Fascia transversalis. Extraperitoneal connective tissue is a layer of connective tissue present between parietal peritoneum and structures forming the abdominopelvic wall. It is named according to its various locations. The fascia lining the transversus abdominis muscle is named as fascia transversalis. Fascia transversalis is adherent to linea alba anteriorly. Posteriorly, it is continuous with the anterior layer of thoracolumbar fascia and renal fascia along the posterior abdominal wall. Superiorly, it is continuous with the diaphragmatic fascia under the diaphragm. Inferiorly, it is divided into two parts. Lateral part is attached to the inner lip of the iliac crest and lateral half of the inguinal ligament, where it becomes continuous with the fascia iliaca. Medial part is attached to the pubic tubercle, pubic crest, and pectineal line, and it prolongs downward and forms the anterior wall of femoral sheath. There is an oval opening 1.2 centimeter above the mid-inguinal point in in this fascia named as deep inguinal ring, which allows the exit of spermatic cord. Comments and suggestions will be welcomed. Thank you for listening and watching.